Okay. We've got Dr. Bruno is next.
Okay, thank you so much for the opportunity to present today. For those of you in the OBGYN department, some of this will feel familiar, but just wanted to go over my area of research on the WERHR K-12 program, which is heparin-based prophylaxis for postpartum venous thromboembolism reduction. So as just a broad overview, venous thromboembolism, which refers to both pulmonary embolism and deep vein thrombosis, contributes to about 9% of maternal deaths in the US. So that's the big splashy, why do we care? In general, the goal here in trying to think about VTE and reduce it is to overall reduce maternal mortality in the US. The reason that VTE is a topic of interest for that is because of that 9% contribution, as well as the fact that compared to non-pregnant individuals, pregnant and postpartum individuals are at about a 5-fold increased risk for VTE. There's multiple factors that accentuate that risk, including things such as maternal obesity, postpartum hemorrhage, infection, and in particular, cesarean delivery is a pretty potent risk factor, and so is one that is highly focused on when we're thinking about this as a research area. This is just highlighting that across the course of pregnancy and the postpartum period, that the first 2 weeks postpartum are the peak risk period for VTE in the obstetric population. So here on the x-axis is the antepartum and postpartum weeks, and then on the y-axis is your rate of VTE per 100,000 person years. And you can see in those first 2 weeks postpartum, after the dotted line is really the peak period, and therefore is the period that we focus on the most as far as our interventions. The current model of addressing this in obstetrics is to take postpartum individuals who are in a hypercoagulable state, consider their individual risk factors, and think about their risk of developing VTE, and if so, the subsequent maternal morbidity and mortality, and to try to intervene in this process to prevent the development of a postpartum venous thromboembolism. That's done through either mechanical prophylaxis, which comes in the form of sequential compression devices or sort of boots you wear on your legs, or pharmacologic prophylaxis, which in the United States is primarily in the form of Lovenox, or enoxaparin, which is a heparin-based injectable medication. So this is sort of the algorithm that we're working with as far as our interventions. This is a busy slide, but just highlights a whole bunch of different guidelines that exist. So essentially all sorts of organizations based off of this postpartum VTE risk have recommended that we take an individual who comes to our labor and delivery unit, has a baby, to then risk stratify that individual to say whether or not they should or should not receive pharmacologic prophylaxis with Lovenox and for how long they should receive it. Those recommendations are not necessarily completely proven, meaning that in our specific patient population, the use of heparin-based prophylaxis has not been demonstrated to clearly reduce VTE, although there's a decent argument that it should, meaning that in non-obstetric surgical fields, there's about a 70% reduction in post-surgical venous thromboembolism with the use of Lovenox. And there's not necessarily a strong reason to believe it would not work in our patient population, so definitely biologic plausibility there. There's population level evidence out of the United Kingdom that following the widespread implementation of a postpartum pharmacologic prophylaxis guideline in 2004, that there was a reduction in their population level pulmonary embolism associated maternal mortality rate. So not efficacy data, but definitely associative data that can be seen at that population level. But when we're really seeking out how do we see this in our actual population to truly demonstrate efficacy, that has not been proven. So there's lots of small randomized controlled trials in postpartum patients that have all been underpowered. When we try to pull those together, the most recent Cochrane review on this in 2021, which is a systematic review and meta-analysis, only had about 1,100 individuals that could be included and could not sort of make conclusions. There were no cases of maternal death, and overall there was a non-statistically significant reduction in VTE, but the conclusion of the authors was that we need more data. And the same thing was true from a more recently published just this year meta-analysis looking at both randomized controlled trials as well as observational studies. So had a larger sample size of about 12,000 patients, but found similar outcomes that in general, there was insufficient sample size to be able to address this question. So where does that leave us? It leaves us in the United States with a lot of uncertainty, where we think that this should work. And many institutions, including our own, have taken sort of the observational data and extrapolation from experts and non-obstetric surgical fields to say that we should be implementing a prophylaxis protocol. So on our labor and delivery unit, we do recommend this for a large swath of our patients, but it's highly debated in the academic setting as to whether we should or should not be doing this. And across the US, depending on which hospital you walk into, can alter whether or not you receive prophylaxis or not. So going back to this algorithm, when we think about this intervention, you might say, why not just do a really big randomized controlled trial and answer the question, right? Always the solution to do an RCT. But the reality of that is that we would need a really huge sample size in order to do that. And there are some other unanswered smaller questions that would need to be addressed before we can really get at that. And when I say large sample size, I'm talking on the order of about 70,000 patients to need to answer this question. So not something that would be super feasible outside of a really large multi-center trial. So my area of focus right now is trying to answer some of these smaller questions. So the first one is thinking about a surrogate outcome. So symptomatic VTE is pretty rare. So trying to find a more prevalent marker that could help us to identify patients who are maybe asymptomatic or in the early stages of development of clot would be really beneficial. Some potential options are doing Dopplers or lower extremity ultrasounds of legs, looking for asymptomatic clots, or thinking about biomarkers to identify those who are at higher risk. And so this is something that I started during my fellowship, but is now ongoing, but is a study basically aiming to determine the rate of asymptomatic blood clots in the lower extremities after C-sections. It is a prospective cohort that's enrolling at 3 hospitals, including the university, that's taking patients after C-section, having them not receive prophylaxis with Lovenox, and then having them come back at 14 days to scan their legs. Second question is the feasibility of individual patient randomization. So again, to do a large scale trial in the future, we would need individuals to be willing to engage in participating in such a trial. And so this is one of the areas that we're hoping to roll out a small pilot at the university in the next year as part of my work that would be aiming to evaluate the feasibility of randomizing patients to Lovenox or no therapy. And the outcomes for this would be feasibility. So taking patients on our labor and delivery unit, approaching them and asking them whether they would be randomized, and basically following them through their postpartum visit to assess whether they stuck to the arm that they were randomized to. So this is something that we'll hopefully be able to better address. And then the other piece is patient perspectiveness and willingness to use the therapy that we're talking about. As I mentioned earlier, Lovenox is an injectable medication that patients are receiving once or twice a day in the setting of being immediately postpartum with a newborn. This is not most patients' favorite thing to receive, as any care providers on our labor and delivery and postpartum units will tell you. So the other aspect of my WRHR research project is to focus on patient perspectives, to really try to identify patients' concerns as it relates to both their perceived risk of venous thromboembolism, as well as their willingness to receive therapies like Lovenox or not. And so the plan is for this to also be carried out in this next year, where we'll be enrolling both patients as well as obstetric providers to interview them in semi-structured interviews and get some qualitative data as it relates to, again, patients' perceptions about VTE and what they would need to sort of think about sort of future aids and education of them, as well as outcomes that are patient informed when thinking about future big trials. And I'll keep it brief, but that's all I have. I'm happy to answer any questions.
Thank you so much. We're going to take a quick break. We want to be back at 4:30. We have the last keynote, Dr. Paula Mackey. You don't want to miss this talk. It's really going to be great. And there's plenty of treats in the other room. So, and those of you that are on Zoom, come on back, take a quick break, but come right back.